This is going to be a short voiceover over the hepatitis PowerPoint. So hepatitis can be either acute or chronic inflammation of the liver. We're going to be talking about viral causes, but some other causes might include drugs, some autoimmune diseases. Most patients who acquire hepatitis, they're going to see it as an acute infection, and most often they can be asymptomatic and it can completely resolve without progressing to a chronic hepatitis. The types of hepatitis that we're going to talk about is A, B, C, and D, and they all have a little bit maybe different modes of transmission, but all of their manifestations, depending on how severe the condition is, will vary. So hepatitis A, we know that the transmission is through the fecal-oral route. Usually we see it in contaminated foods and drinking water, maybe in restaurants where there are outbreaks of hepatitis A, maybe daycares where there's an outbreak, or maybe even in underdeveloped countries where the drinking water is contaminated. So usually via unwashed hands. The incubation period is about 15 to 50 days. And I think the literature does say that maybe a couple weeks prior to a patient who has Hep A showing symptoms, they are highly infected, which means obviously if a patient doesn't know that they have Hep A, they're not having symptoms, they're not being screened, it's likely that if you're in close proximity to this person, you could acquire hepatitis A as well. So again, manifestations vary. Flu-like illness, and often they can be asymptomatic. People who get hepatitis A, this will confer their lifelong immunity. So hepatitis A does not progress to chronic. So if patients who get the hepatitis A vaccine or actually have a hepatitis A infection, they will develop lifelong immunity. If you look at the CDC website for the schedule of vaccinations, hepatitis A is listed on there as a recommended vaccine. It's usually given in 2 separate doses, and you can get the one as early as 12 months of age. And usually they're spaced out between 6 to 18 months. So definitely an decrease in incidence since vaccination. And we've got 2 serology tests that we look at with hepatitis A, and we need to make sure that we know IgM shows an active infection versus IgG shows a past infection or that the patient has immunity, whether from an active previous infection or from vaccination. So don't forget that. IgM serology is targeted at active infections. All right, so hepatitis B, we know this is typically through percutaneously via blood. Any type of fluid secretions that have blood in it has the potential to transmit hepatitis B. It's considered a DNA virus, so we can get it perinatally from a mother who's infected to her child, percutaneous, healthcare workers with IV sticks, IV drug use. And then again, any type of fluid, even if it's feces that has blood in it, has the potential to expose somebody who doesn't have hepatitis B virus. So the incubation period is pretty long, between 28 to 160 days. Again, just like hepatitis A, the manifestations can be very vague and general, just like flu-like illness. The difference with hepatitis B and A is that hepatitis B can progress to a chronic state. More commonly, though, the patients with hepatitis B will resolve on their own. And so again, with vaccination and with having an active infection of hepatitis B will confer their immunity at some point later. There are multiple different serology and diagnostic tests for hepatitis B. I think what I want you to remember is that there are 3 types of antigens. There's a surface antigen, a core antigen, and an E antigen, and they all have corresponding antibodies that develop over time. The one that I want you to focus on is the surface antigen and the surface antibody. A patient who has anti-HBs, which is the surface antibody, lets us know that they have lifelong immunity to either the vaccination or previous infection. And that's important for you to remember. Populations who are at risk for hepatitis B, like we said, homosexual sexual activities, any type of kissing between genders, especially if it has the potential to have blood in it. Household contact with somebody who's got a chronic hep B infection, because it does, I think, live on inanimate objects for like 7 days. So if you've got an open lesion, an open tear, and you touch the area. Patients who undergo hemodialysis, where I think there's probably a decreased incidence in this due to testing. And then healthcare and public safety workers who are not vaccinated, transplant recipients, but I think that could be pretty low. Hepatitis C, similar in transmission to hepatitis B. We think IV drug use, high-risk sexual behaviors, occupational exposure, and then dialysis. And transfusions before 1992, before they started actually checking for the HC virus. So if anybody had received a transfusion or transplant maybe prior to 92, I might consider them high risk. Incubation period is somewhere between 15 to 160 days. And as we talked about in class when you guys took this quiz, most patients, somewhat similar to Hep A and Hep B, are asymptomatic. And so the difference with hepatitis C is hepatitis C can progress, and most often does, to a chronic form because the patients are unaware in the acute stages. So without early identification and treatment to prevent the progression to chronic, they're usually going to develop it. And worldwide, chronic hepatitis is the #1 cause of cirrhosis. So there are multiple, again, serologies, diagnostic testing for Hep C. What I really want you to know is that there are multiple genotypes and subtypes for hepatitis C viruses. And how that's important is to know that even if a patient has acquired maybe another genotype or subtype of Hep C, it doesn't necessarily mean at some other point they couldn't acquire another genotype. And it's the same thing with Hep A and Hep B. Even though they have lifelong immunity to Hep A and Hep B, they still could acquire Hep C. So important concept, though, about subtypes and genotypes. Before treatment is started, if a patient is screened and it's identified that they actually have hepatitis C and they start them on antivirals, they're going to want to know what the specific genotype and subtypes are so that they can target treatment. So that's an important component to remember. Hepatitis D, remember we said this is a Delta virus and it can't stand alone. It's impaired, so it actually needs hepatitis B to replicate and to stay active. So again, the same transmission as hepatitis B. Again, range from asymptomatic to acute failure. Some of the symptoms, right, very flu-like. So makes sense. There is no vaccine for hepatitis D, but by receiving the hepatitis B vaccine or having, lifelong immunity, we see a reduction in the incidence of hepatitis D virus as well. There are serology tests for it as well. But I think it's important for hepatitis D to know it can't stand alone. It needs hepatitis B to replicate and be active. And that hepatitis B vaccine has been known to cause decreases in the hepatitis B incidence. All right. So regardless of whether it's A, B, C, D, with an acute infection, we know that there's liver damage from the actual lysis of the infected hepatocytes. So the liver cells become lysed and damaged. This damage and inflammation and irritation can interrupt bile flow from the liver through the bile ducts. And it can also kind of alter its function as well. But we know if they're able to progress and heal and come out on the other side without a chronic infection, that the liver cells can actually regenerate and can take the liver function back to normal. But patients who develop chronic hepatitis B or hepatitis C, they are also their liver is probably going to continue to progress and become very fibrotic and lobulated in shape and smaller, and it's going to actually progress to cirrhosis. So clinical manifestations, like we said, very vague, often asymptomatic, and so very flu-like, right? Fatigue, myalgias, arthralgias. If we were to do a physical exam on this patient, we'd palpate for their liver. We do the span of the liver. If we actually did a measurement, we would see that they have hepatomegaly. They've got an enlarged liver. The acute phase, if somebody has an active hepatitis, is going to range somewhere between 1 to 4 months. And just like some of the symptoms we talked about, the flu-like, they can also have a lot of anorexia and weight loss. And most often they have altered taste sensation, right? Smokers sometimes feel they have a distaste for cigarettes. They just don't want to eat. So there's weight loss, which we know is a problem because we need calories to help in the healing process and regenerate hepatocytes. All right, so again, physical examinations, hepatomegaly. This might be a time where we can actually palpate the spleen. Largely, when we go to palpate somebody's spleen, we can't find it, right? That's normal. There's inflammation going on, so we might have some regional lymphadenopathy, so we might have some enlarged lymph nodes. And then we said, depending on the degree of inflammation and whether the bile ducts are obstructed or not, or whether the bile production is altered, patients can be icteric or anecteric. So that just means, are they jaundiced or are they not? Are they able to conjugate the bilirubin? Are they able to produce bile and move it to the gallbladder or not? So that's the only difference. Do we have bile or not? So if patients are icteric, they don't have bile. Same thing with the cholelithiasis. We're going to see jaundice in their skin, in their sclera, maybe in the oral mucosa. We're going to have bilirubin that spills over into our urine, so it's going to be tea-colored, frothy. No bilirubin in our stool, right? So it's going to be light in color, clay-colored. And then if bile salts, which we need for fat breakdown absorption, is going to accumulate under the skin, we're going to see a lot of pruritus or itching. All right, so when we move to the convalescent period, this just is usually going to last between 2 to 4 months. And it's just kind of like you said, a convalescent period. Things gradually or insidiously start to subside away. So you still might see the enlargement of the organs, organomegaly, and some of the flu-like symptoms, but they're improving. They're just slowly getting better. Like we said, recovery with hepatitis A and B, if they recover with the hepatitis B and don't progress to a chronic, they're going to have lifelong immunity. But we need to remember with Hep B and Hep C, if they do progress to a chronic before treatment, we need to know what subtypes and genotypes there are. Mortality rate for an acute hepatitis event is going to be less than 1%, but they found that the highest risk patients are older adults and maybe some with coexisting illness. Any types of synergistic activities, so excessive alcohol use, excessive triglycerides, maybe being diabetic. Okay, so some of those coexisting conditions can cause synergistic effects and increase the mortality of somebody with acute hepatitis. So obviously the complications in severe forms, acute liver failure, end-stage renal disease, a chronic hepatitis. We said some patients with hepatitis B can progress to chronic, largely in part though they will resolve and they'll heal on their own. But most patients with Hep C in the acute form will progress to chronic because remember, they're asymptomatic. They don't know. So they're not being treated early enough to prevent the progression. Okay. Obviously, cirrhosis is a large complication of chronic hepatitis B and C. And then 80% of all liver cancer is directly related to chronic Hep B, Hep C. All right, so diagnostic studies. There's a separate handout, another handout section for week 4. And it does talk about the specific antigen and antibodies for each type of hepatitis. I think I've clearly identified what you need to know for each one. Liver function test, like we said, elevations in ALT, AST makes sense. I think the elevation is going to correspond to the degree of injury to what stage these patients are in. So if it's at their peak, I think we're going to see an more elevated ALT, AST, alkaline phosphate. And as it starts to subside, there's going to be a drop. And then bilirubin is going to depend on whether bile production is altered or if the liver is not able to conjugate bilirubin or not. We talked about genotyping, subtyping before treatment for Hep B, Hep C to specify antivirals to the right type. We talked about the physical assessment findings, right? The organomegaly, right? The enlarged spleen, the enlarged liver, altered taste sensation, weight loss, anorexia, all things that impair the recovery. So liver biopsy is probably the most specific diagnostic test for an accurate diagnosis of liver impairment disease. But there's a lot of risk to liver biopsies, especially if a patient actually has hepatitis or a chronic condition, because we know it can alter clotting factor production. So these patients are high risk for bleeding. Okay. So there are more newer types of diagnostic studies that are out there that aren't as invasive, that are more minimally invasive, like FibroScans and FibroSures, that are closer to assessing the depth of injury, degree of injury, without actually having to take a specimen out of the liver for biopsy. So collaborative care, like we said, we want these patients to be on a very well-balanced diet with increased caloric intake for hepatocellular recovery. But we're going to see it more from carbohydrates, not necessarily from fats. And that is, again, going to depend on the degree of if the patient is able to make bile and it's able to be utilized well. So that may be based on patient's tolerance. Are we seeing any indications where they're not making enough bile? So massive diarrhea, steatorrhea. What's the alteration in the color of the stool in their urine? So increased caloric intake, but more from carbs. Yes, adequate fluid volume status. And yeah, we're going to make sure these patients get well-balanced diet with adequate vitamins. And again, depending on the degree of injury and whether or not they make bile salts, can we adequately break down and absorb fats and help it to utilize the absorption of fat-soluble vitamins like K, A, and E. So rest promotes hepatocyte regeneration. And obviously during this time, even though that's not necessarily the causative factor, we don't want to minimize any hepatotoxic drugs. Acetaminophen, aspirin, sedatives like Xanax, Ativan, benzodiazepines. They don't necessarily injure the liver, but they're going to not be metabolized correctly, and their risk for buildup is high. And then any type possible notification of possible contact. So maybe sexual activity, IV drug use, sharing needles. This might be an important topic to discuss. Notification to possible contacts from these affected individuals. All right, so drug therapies, again, there's a separate handout sheet under week 4's handouts. So hepatitis A, we said these, they're going to resolve on their own. It's self-limited, so no drug therapies, just supportive care. Acute hepatitis B, usually we said this can resolve as well. It doesn't necessarily always progress to chronic, but we're going to only use drug therapies, antivirals, if the hepatitis is severe and if we start to see some indications of liver failure. Hepatitis C, an acute infection, we will use medications to prevent the progression to chronic if we're able to identify it. So usually within 12 to 24 weeks, if we start medications such as interferon, it's been found to reduce the incidence and progression to chronic C. And then supportive therapy. Obviously, antiemetics, right? If these patients are nauseous, they're vomiting, we might consider some of these medications. I think we're more apt to be wanting to consider this medication, maybe this secondary, as we know some of the side effects of Phenergan promethazine are lethargy. So chronic hepatitis B, we said, can happen, doesn't happen as much as hepatitis C, but the goal of treatment with antivirals is to decrease the viral load, increase the risk of infectivity to somebody else, help bring down the liver enzymes, and decrease the rate of progression in the overall disease to cirrhosis. Again, there's a few different types of medications that can be used with chronic hep B. Interferon, pegylated interferon, which is interferon which is just adjusted a little bit so that the medication stays in the system longer, so it doesn't have to be given quite as frequent. And then some of your nucleoside and nucleotide analogs. All of them work on decreasing viral replication. So again, if you're curious, take a look at the handout. And then common sense, a lot of the side effects from these medications is immunosuppression. Okay? So these patients who are getting some of the antivirals, they're at risk for getting some opportunistic infections. So often you'll be watching their white blood cell count. Targeting therapy, you're looking at their liver enzyme levels. If this is working, if these antivirals are working, we're going to see decreased rates in their liver enzyme levels. Some other side effects, anemia, maybe the platelet count might drop, and then even maybe some flu-like symptoms as well. And then chronic hep C, so some of the treatments for chronic hep B and chronic hep C overlap a little bit. So our goal with hepatitis C is to eradicate the virus and also to prevent any type of HCV-related complications or the progression to cirrhosis. And again, the types of medication, antivirals, are listed on the handout. And then all of your patients who are receiving antivirals for chronic C, they're at increased risk for depression. Okay, and it's because a lot of the adverse effects from the medications can be mood changes. So we want to make sure that we're screening these patients for depression prior to starting therapy. And we're going to continue to monitor them for changes or improvements throughout therapy. So the subjective data, all kinds of the things that we talked about already, like who are our high-risk patients? So if we're looking in their past health history, what is their risk factors for acquiring hepatitis? Medications, just like we talked about, any of them that are hepatotoxic, not necessarily have they caused the hepatitis, but we do know there are drug-induced hepatitis. Are they acting as a synergistic effect to the liver failure? So if a patient has hepatitis, we need to be decreasing or avoiding the use of them altogether. So like we said, distaste for cigarettes and some of the phases of the acute hepatitis. Anorexia, nausea and vomiting, so weight loss. This is a problem, right? We want our patients who have acute hepatitis to heal. And so we want them to be able to eat and increase their caloric intake. Right upper quadrant ultrasound, right upper quadrant pain makes sense. We're going to be looking at alterations in the urine and stool if there's a decrease in bile production or the conjugation of bilirubin. In the convalescent and the acute phases, right, organomegaly. And what abnormal lab values are we looking at? AST, ALT, alkaline phosphate, bilirubin. All right, and so discharge or nursing diagnoses. I mean, the risks are many. Risk for injury, risk for bleeding, obviously activity intolerance. These patients are tired, they're fatigued. Imbalanced nutrition is a large one, right? Less than body requirements. And I think we can relate that to a lot of things. Not only is it the acute process itself with active hepatitis, if patients have chronic and they're on some of those antivirals, anorexia, weight loss, they're not wanting the patients to eat very well. They don't stimulate the appetite. So our goal is really normal liver function without complications, relief of that right upper quadrant discomfort, and resumption of normal activities. So hepatitis A, we said the number one thing that we can do to prevent the progression or to prevent the contraction of hepatitis A is hand washing. Good sanitary care, adequate personal hygiene, active immunization. Isolation is not necessarily required in the hospital unless we worry about copious diarrhea in the area, not being cleaned well. We can do post-exposure prophylaxis to patients who have been in close proximity for a while to somebody who's had hepatitis A. And we said necessarily, even if they don't have symptoms, we know they're fairly infective prior to showing symptoms. Okay, so in the incubation period, they might not have symptoms, but they are infected. Okay, so there is an active immunization for HIV. It's a two-step process. We said as early as they can start is 12 months of age. And then if we have been exposed or we suspect, we can do post-exposure prophylaxis. Okay. So good hand washing, environmental sanitation, screening of food handlers if there's an outbreak in a restaurant. Isolation in the hospital is typically not required, but if there's a lot of diarrhea, not clean environment, we might consider it. So hepatitis B, right? Identify our patients at risk. Screen any type of donated blood. We know it's been done since the early 90s. Hand washing, gloves, but definitely hand washing if we feel like we've been exposed. Okay? And then typically, you're going to your charge nurse. You're going down to the ER to find out what you need to do. Hopefully you have had the vaccination, so we're not worried about it as much. Using disposable needles and syringes. So our needleless or the quick ports that pull back over our needles when we're using them for IM injections, sub-Q, or even when we're sticking for an IV. Don't be sharing any types of equipment or devices that could have blood infused secretions on it. And if you're having sex, making sure you're using condoms. And we said 95% effective usually is the vaccination, provides active immunization, and there is post-exposure prophylaxis. So we usually want to do it within 24 hours of exposure. So hepatitis C, so there is no vaccine. So some of the same measures that we're talking about with hepatitis B to prevent the progression or the transmission of HCV. So some of your patients who have been screened born between 1945 to 1965, there's a concern. We weren't really screening blood products, organ donations prior to 92, so that would definitely make sense. There's no post-exposure prophylaxis if somebody's been stuck by a needle with somebody that has hep C. What they typically will ask you to do is you'll get like a baseline test for hepatitis C virus and your liver enzymes, and then you'll continue to follow up. So it's not unless you test positive that they'll start some of the antivirals. Okay? So currently right now the CDC does not encourage post-exposure prophylaxis with immunoglobulin or antivirals. All right, like we said, in the acute stage, acute care, we're assessing for jaundice. Is this patient icteric or anicteric? Okay. And that's all going to depend, again, is the bile ducts obstructed? Is the liver able to conjugate the bilirubin? Okay, so different places we're looking. If patients have pruritus from the accumulation of bile salts under the skin, comfort measures. Adequate nutrition, we talked about that. High calories, increased food or increased fluids. If these patients are having a hard time eating, maybe we're going to do small, frequent meals. And we're definitely not going to be rushing them. And we're going to be doing things to stimulate their appetite, like good oral hygiene, making the environment where they're eating aesthetically pleasing, making sure the foods are the way that they want them. Is it not too hot, not too cold? These patients need rest, right? We talked about that. And so sometimes in the hospitals, it's difficult. So we need to balance, small progressions and activities to rest so they're sleeping well at night and they're also getting their downtime through the day. So we might have times where we're limiting visitors, limiting a lot of stimulation. So these patients are going to have pretty much activity intolerance when they're starting to recover. So we're going to have to definitely gradually build their endurance, increasing their muscle mass, respiratory endurance. Like we said, the psychological and emotional rest, we might have to limit environmental noise. And then diversional activities. If these patients aren't very active and they had been an independent, active person, it's going to cause, I would think, a lot of emotional, mental issues. So diversional activities, readings, other hobbies, okay, things that are going to distract them so to minimize anxiety, production, restlessness. All right, when the patients go home, we've already talked about like dietary teaching, increase calories, fat only if kind of tolerated, so gradual introduction into fat, high fluid intake, adequate overall nutrition, good vitamins. Talked about activity, gradually building endurance. These patients are going to be tired, they're going to be worn out. We want to make sure they get plenty of rest. We talked about how to prevent transmission, especially with Hep B and C, condoms when sexually active, and when to report to the physician. So I would think any types of bleeding risks, if these patients truly have a problem with fat-soluble vitamins being absorbed, especially vitamin K, are they at risk for bleeding from their gums, their stools, their urine? And then in the very severe acute stages of active hepatitis or chronic, we do worry about not being able to kind of utilize the ammonia and put it to urea to be excreted in the urine. So we are kind of watching for signs and symptoms of encephalopathy. And we know with encephalopathy, risk factor for safety. There's problems with safety. So definitely no alcohol use. Okay. If the patient's going home on antivirals that they actually have to administer themselves, some of them are sub-Q, and so they're going to have to be taught how to administer the interferon, the pegylated interferon. We're going to have to talk to them about some of the side effects, and again, see the handout just for your own information. And so if we're not going to be doing a lot of drugs because of the interactions or the complications with the liver impairment, we're going to have to be using some of those non-pharmacologics, relaxation, distraction, guided imagery, deep breathing, aromatherapy, music, and then obviously common sense. Patients who have Hep B, Hep C, we're not going to allow them to donate blood. They're not going to be candidates. So our expected outcomes: adequate nutritional intake, increased activity intolerance or increased activity tolerance. We want them to build their energy, build their tolerance. Periods between rest and activity. And then doing things that we can do to prevent the progression from acute hepatitis to chronic, and also the methods that we talked about decreasing the prevention and the transmission to somebody else.